Okay, stage 2 is pushing. It is from full dilation to baby delivered. So we're going to talk about the nursing care that we give in stage 2. One thing I want to talk about for just a minute, though, is how that's traditionally been done. In the last couple hundred years in the US, maybe more like the last 100, somewhere around there, starting in probably early 20th century, women who were completely dilated were encouraged to start pushing immediately. And they would be encouraged to push to push as hard as they can with a prescribed pattern, usually someone counting, in order to try to move the baby down. When I started practicing in labor and delivery, when I moved to labor and delivery in the mid-90s, we still would be in the labor room with a patient who's completely dilated, and usually we would have them right away start pushing, and we would have them try to get 3 good pushes each contraction, count, each push was to the count of 10, then take a breath and come back. So that's coached pushing, and that's a pretty common way that pushing has been done for the last actually quite a while. But that's not the way it has been done everywhere. In some countries, it's been done differently, and midwives tend to do that a little bit differently. It's much more common in a lot of the world to wait until that patient has the urge to push. That's called delayed pushing. So what are some of the pros and cons of each? Well, with delayed pushing, and that's waiting until the patient has the urge to push, or if they have an epidural, they might not have an urge to push, but they still will labor down. They call it laboring down when they allow the patient to move, the baby to move down without active pushing. So some of the benefits: stage 2 can be longer, so there's a longer time between full dilation and birth sometimes, but they may have less time actually pushing, so they're less exhausted. They may also be less likely to have a vacuum or forceps assisted birth because they don't start pushing as soon, so they're not exhausted by the time they deliver. There's not a significant difference either way in C-section rates, lacerations, peritoneal lacerations, episiotomy rates, or fetal complications. Okay, so they're the things that they've measured. Those are the things that there's not a big difference either way. But if we allow them to labor down and wait until they have an urge to push, or pushing is involuntary, then we're less likely to have operative births or assisted deliveries. Shorter pushing time, but stage 1 is longer. Okay, so there's a lot of evidence that supports delayed pushing or laboring down. Another thing that we want to think about is the position for birth. The lithotomy position was invented basically when doctors started doing births. That was not the traditional way that patients delivered. And the primary benefit of the lithotomy position is it allows greater visibility for the person delivering the baby. Not that you would discount that, but just that that's the primary reason for that position. Lithotomy is laying supine with the legs up in stirrups. Okay. So more recently, there have been other options offered to people. Someone might push while squatting, while side lying. In the UK, a lot of people give birth side lying, or encouraged to push side lying, because it tends to slow birth and decrease the tears. We're not used to doing it that way most places in the US, so we're kind of like, hey, what are we doing here? But that's a common option. Some practitioners will have patients try to push on hands and knees, or using a squat bar. There are birthing stools, which is like a chair, but it has a cutout to allow for the delivery. So there are a lot of different options for pushing. What patients are allowed or encouraged to do is going to be really, really closely linked to hospital policies and the preferences of individual practitioners. During pushing, it's really, really helpful if the patient has a support person that's not the nurse, because the nurse is going to have a lot of tasks that have to be done to maintain safety, and it can be difficult to do that while while also being the emotional support person. I have been in the room when it was me, the doctor, and the patient. It can be done, but a lot of that reassurance is verbal as I'm doing other things. So if they can have a support person, it's very helpful. Supplies and equipment. Sterile instruments are set up in advance of the birth if we have enough warning. Birth itself is not sterile, but any instrument that enters any orifice, so anything we put in the vagina, or any instrument that pierces tissue, so think needles, things like that, those things should be sterile because we don't want to create infection. Birth itself is not a sterile process. Some providers still drape during the birth. They drape the abdomen and the legs with sterile drapes. I don't know that that's evidence-based, and I know quite a few providers who don't do that. But one thing we do know based on evidence is that if we put an instrument into a person, or if we pierce a person's skin, that needs to be sterile. So supplies and equipment should be set up. The sterile birth kit should be set up in advance, and there should be emergency equipment available for both maternal and fetal resuscitation, or newborn resuscitation. Once it's out, it's newborn. We need to know how to notify the provider in time to arrive, and that is an art. If we call the provider too soon, they get frustrated, they get impatient, they have patients waiting on them in clinic. So there's other things they could be doing while they're waiting for this delivery that we call too soon. If we call too late, they miss the delivery, which can increase some risk. If there's a complication and there's not a provider there to handle it, that can be a problem. So you have to learn how to call so that they're coming in shortly before delivery. We need to be prepared for immediate postpartum and newborn care. And that means we need to have a warmer on and prepared. We need to have a warm place to put the infant, and we need to have adequate IV fluid, any medications we expect to need, usually some Pitocin or some other oxytocin for immediately after birth, so that we don't have to leave the room to go get those things. So we need to have those things in the room and ready to go. Fundal pressure when pushing is not usually recommended. There are very rare cases when it might be, but in particular, when someone is if someone has shoulder dystocia, don't use any fundal pressure. So you see sometimes in videos, somebody will be trying to push the baby from behind. That's not recommended. We also need to be prepared to do an emergency delivery if the provider does not arrive on time. And the steps for that are on page 402. Okay, so that's the second stage nursing care piece. We've got to have everything ready in case of emergency, all the things ready for the immediate delivery and right after, while we are providing emotional support and monitoring for that patient. Remember, we're also monitoring maternal vital signs, fetal heart rate patterns, and contractions. Okay, the next section is going to be nursing care in the third stage, the delivery of the placenta.